go ahead now with next talk. And your topic will be aorta osteo lesions, my approach. I think very, very difficult part in interventional cardiology. And I'm really happy to see you and to join your lectures. Welcome.
Thank you. Thank you for having me here. And I hope you can see my slides.
Yes, perfect.
Okay. So let me take you to a couple of cases. This is a 50-year-old lady who is hypertensive, diabetic, recently diagnosed diabetic. She had a angioplasty to osteoproximal LAD some 7-8 months back and returned symptomatic. And you can see here a tight osteal left main disease, as is very evident in most of the views. So I straightly wired, used a cutting balloon, and I did a rota in this case, although it is not the preferred imaging modality, but it was basically to see the lie of the osteoproximal stent. Was it crossing the circumflex into the left main or not? And as it was evident, the stent had started from the distal left main. So I used a stent to just cover up, this distal, the proximal end of the previously deployed stent. And you can see here the effect of the cutting balloon, the scores you can see in the triangular fashion at the ostia. And I used an angiographic guidance to deploy the stent. And my stent was just overlapping the distal stent. Used a larger balloon to flare up the ostial ledge. And this was the final view. And you can see here the circumflex ostia was paired and the stent was entirely deployed optimally. And these were the final angiographic images. Now, this is another case, a 55-year-old gentleman who had presented with an acute coronary syndrome and presumably new onset LBB with raised troponins. He was treated at another facility in some other different state. And the stenting was done in the mid-distal LAD. And he was advised for physiological assessment of the ostial left main because that was an acute coronary syndrome like STEMI-like situation. So the operator avoided that. And he had come here, and you can see here in various projections, the ostial left main. And here I did an FFR. Very importantly, when you do an FFR, the equalization has to be done in the aorta. And the FFR came out to be significantly positive of 0.74. So went ahead with the stenting of the lesion, again, an angiographic guidance. But if you look at here, I needed a different view. And this is the areocranial to ensure that my stent is just across the aortosteal plane and deployed, flared up the edges. And these were the final views seen in the OCT. And OCT, again, I preferred it in this case to see the distally deployed stent. And these are the final angiographic images. So for he also had a right ostial lesion. And again, for the right ostial lesion, again, my guide was not very steady and helpful in this case. So I used a buddy wire into the main vessel and used this FFR wire to equalize in the aorta. And subsequently, I wired the RCA with the FFR wire. And here the FFR in the RCA was negative. So it was left on medical management. So a quick, for the youngsters who have joined, a quick step-by-step approach. We use a lesser aggressive guide to hook the main vessel when you have an ostial disease. And usually, if the ostial lesion is very tight, we preload the wire and try to move with a hit and run. And once we have wired, we dilate the vessel, prepare the vessel. If calcified, needs a plaque modification. Then we, selectively again, you have to selectively again engage and disengage. We engage the aorta, push the stent beyond, slightly disengage, ensure that the stent is covering the aortosteal plane and 1 millimeter protruding into the aorta. This is when you are doing an angiographic guidance. Deploy the stent, pull back the balloon, flare up the edges, and then on that deflated balloon, you try to make the guide coaxial and selectively hook so that if you need a downstream, again, some intervention, or you need to post-dilate, your guide is co-aligned. And this is when you finally assess, disengage the guide. Final shots can always be taken over the wire because sometimes once you remove the wire, your guide may not be coaxial to profile the stents. So aortosteal lesions, as it sounds, it has two parts. The osteal lesions are lesion 3 millimeter from the origin of the coronary vessels. It can be divided into the aortosteal lesions, which include the left main, the right coronary ostia, and the aortosteal bypass grafts. The non-aortosteal lesions include those in the major epicardial vessels like the LAD circ and the RCA, and the branch osteal, which involves the major branches of these vessels like the diagonal OM and the PDPL. However, the prevalence of the aortosteal lesion is too low. It is reported in 2.6% in the registry of the real-world unselected patients. This low prevalence renders it difficult to study, and the data are mostly from registries and limited data on the cases. Isolated aortosteal lesions are more frequent in women and in RCA, mostly atherosclerotic. Non-atherosclerotic lesions include the aortoarteritis, mediastinal radiotherapy, previous aortic valve surgery, congenital atresia, and extrinsic compression as by the dilated pulmonary artery. Indications remains the same as in other scenarios that include the unstable angina, other acute coronary syndrome, and stable angina or dyspnea. However, there are challenges for the PCI of the osteal stenosis. This include the anatomical and physiological assessment, resistant to the dilatation as they are more prone to recoil. The PCI techniques and the adjunctive devices may be needed in difficult cases, and we use DES and image guidance nowadays. The complications include the geographical miss and the other complication, remembering in mind the large area of myocardium is at risk. So what we prefer is a lesser aggressive curves of the guiding catheter, because more aggressive curve selectively jumps in. Preferably use a Judkins catheter, and it also helps in imaging when you have to repeatedly disengage the catheter, as also in the physiological study. But when you are doing a plaque modification, particularly like a rotational atherectomy, you need to hang out your guide, disengage it, and ensure that it's still coaxial so that your rotabur hits the osteal lesion in a coaxial pattern. The lesion assessment is maybe based on the angiography or physiological assessment or by QCA, but QCA is, because of the lack of reference, is always overestimated. So angiographic assessment, one has to ensure that the left main ostia is profiled without any foreshortening. And the suggestive features are there is significant damping or ventriculation of the pressures and lack of reflex. However, sometimes, when we deeply intubate the catheter, we might miss the osteal stenosis. We have to rule out the spasm. And again, as far as when it comes to angiographic assessment of the severity, we have to remember we do not have any proximal reference. So therefore, physiology and imaging are better assessment. It helps you in strategic planning and better clinical outcome. However, it takes time, it costs money, and it needs an additional equipment. Whenever we are performing in the FFR, the most important thing is in the aortosteal lesion, we must equalize in the aorta. And sometimes to do that, we might need the buddy wire, as I've already shown. And the cases that I showed you were isolated osteal diseases, but there might be sometimes downstream diseases, most often actually associated with such kind of situations. So here we use preferably an IV adenosine instead of intracoronary, because intracoronary does not give you an ideal assessment. When it comes to morphological, IVUS is slightly better than ostia because it can profile the ostia in a much more better way. It can confirm or refute the presence of disease, rule out spasm. It gives you a characterization of the plaque, including the calcium distribution. It gives you the vessel size, most importantly. And again, sometimes during the procedure, we can use the IVUS for stent positioning. And post-procedure imaging helps you to give an optimized result and ensure that there's no geographical miss or protrusion in the aorta. However, there are caveats. The imaging is a non-physiological, and sometimes guide catheter pulling back may cause loss of coaxial imaging and therefore an overestimation of the MLA. As far as the stents are concerned, DS is preferred because of the lower TLR. Importantly, they should have a good radial strength. And most importantly, we must know which stent we are using and what is the relationship between the stent edge, the proximal stent edge, and the balloon marker. Zine's family, the marker is half covered, while rest of them are 0.5 to 1 millimeter away from the marker. When it comes to stent positioning, we must again appropriately profile the ostia without any foreshortening. And sometimes additional or non-standard views might be required. And stent positioning most often is done in angiographic view, but other techniques are also there. I'll quickly go through them. This is the angiographic positioning. We look at the aorto-osteal plane, slightly protrude the stent, remembering that what is the relationship with the balloon marker. If the stent is balloon marker is covered with the stent, we can position here. Else we must be vigilant enough to see that stent edge has come just 1 millimeter beyond this osteal plane. And then we deploy the stent, pull back the balloon, flare up the edges, and make it more coaxial. However, the angiographic deployment has some difficulties because repeatedly you have to disengage the catheter, you have to have multiple views, and disengaging catheter needs a large volume of contrast to profile. You have a bobbing motion, both the cardiac and the respiratory motions, so one must take care of that. And geographical miss has been reported in 54% cases, proximally in 52, and distal in 48% cases. And TLR increases threefold higher if you have a geographical miss. So the other techniques which ensure more steady deployment are, one of them is a floating wire technique where you have a second buddy wire in the outside in the aorta. And what it does, it actually helps prevents the guide catheter being sucked in, and it helps you to profile the ostia and deploy that. Another technique can be, instead of a buddy wire, you can have just a goose snare. Again, doing that, you need not inject the contrast. The goose snare will give you the profile where the ostia is sitting. Another technique is the Zabo technique, or this tail wire technique, where the stent is slightly before you deploy the stent outside. You just flare up the proximal and thread the second wire, which is in the aorta, through the proximal struts. And this is one or two cases I have done. This is one of the Zabo method which I used here. But unfortunately, the acute results are good, but has shown that there are a lot of deformity in the stent. So and the recrimping sometimes, if not proper, can cause the loss of stent. IVUS guided, again, here you place the IVUS in your sepal wire, floating aortic wire, and you can see here, like, the stent edge when you are deploying, and this is how it is profiled, and you can deploy it on the IVUS guidance. So the working algorithm is, once we wire, we ideally should look at whether the lesion is calcified or not. If it is heavily calcified, we need a rotational atherectomy. If not, we need a specialty balloon like cutting balloon, or either Flextrom or Wolverine, or sometimes non-compliant balloon. Once we do that, we must image, look at the reference diameter, look at the length, mark the landing zones. As I said, this is the aorto-osteal plane. We just need to protrude 1 millimeter beyond that. We stent it, do an imaging again, and post-dilate to have an optimal results. Another situation subset of this is the aorto-osteal CTO, which is very hostile subset, but time constraints may not help me to present this. But most often, antegrade wiring techniques are difficult in such situation, particularly if there are flush occlusions, and retrograde approach is often resorted to. Otherwise, sometimes, IVUS guided penetration is needed. Now, this aorto-osteal CTOs are independent predictor of the procedure failure, and we have very limited information regarding the outcomes and the technical aspects. There are some dedicated devices for the aorto-osteal. One of them is the Osteo Pro, which helps you in the accurate stent placement in the osteal. The other is the Flash Osteal system, which is a double balloon, helps you to optimize and the stent deployment and flare the proximal edges, but very few balloons have been used. There are complications, and the complications include a geographical miss. And for that, we need a little bit longer stents, more breath holding, maybe sometimes rapid pacing and IV adenosine, or some of the other guidance technique, as we already discussed, the IVUS guidance, the floating wire. And if it has happened, we might need a second stent. The other situation is the excessive protrusion of the stent in the aorta. And in such cases, we might need flaring of the edge, and osteal flash balloon system are often helpful. The third complication can be because there is stent under expansion or recoil, and the worst scenario, sometimes a peripheral stent like a renal stent has also been used where the stent recoil happens repeatedly after a lesion. One of the important thing is the protruding of the stent. In excessive protrusion, rewiring is very difficult. So this is one interesting technique which I actually had read and I had practiced in a couple of situations. This is called balloon assisted access to the protruding stent, where actually you wire in through the protruding stent, use another balloon here, and when balloon touches the stent, the guide disengages and it is more coaxially aligned. And the second wire with a loop, we can go in through the true lumen, and then subsequently things are easier. Also, there can be a stent deformity. This happens when we try to remove an incompletely deflated stent balloon into the catheter. Often the guide hits the stent and deforms the stent, especially the two connector stents. And also, if we are doing a left main-like disease, when we try to remove the jailed wire, again the guide catheter, if we are not careful, moves ahead and hits the stent and causes the deformity. So the other complications include the guide catheter-induced dissection, the plaque shift, the branch closure, and sometimes you have lost the wire position and you are unable to again rewire it, edge dissection and perforations. So to conclude, aorto-osteal lesions are challenging coronary subsets with complex lesion and procedural characteristics and technically demanding. Precise knowledge, advanced skills at hand, and having tools help to overcome the challenges. They are frequently fibrotic, rigid, and calcified, needs plaque modification. PCI techniques have been associated with lower procedural success and more complication in hospital complications compared to the non-osteal lesions. Complications are prone to occur and include dissections, loss of guide position, stent deformity, geographical miss, and excessive protrusion into the aorta, inadequate expansion. And special techniques prove helpful that include the tail wire or the Zabo technique, or special devices like the Osteo Pro system and the Osteo Flash. And imaging is also very important in such cases. Thank you.
Okay, Dr. Roy, thank you for your really fantastic presentation. So with all these difficulties we have in our cath labs, if we go primary to treat osteal lesions, I think my last short final comment, don't forget, I don't know if you have shockwave balloons in India, but it is really very, very useful tool for osteal lesions. You could really make final post-dilatation and